Have you been troubled with lower lumbar back pain that's been going on for quite some time and hasn't improved? Maybe you've seen numerous practitioners over the years. They've carried out some tests, including an MRI. They've given you various theories as to the cause of the back pain, but you haven't really seen a definitive result. My name's Anthony Ghosh. I'm a consultant spinal neurosurgeon and founder of the Spine MDT. In this video, I'm going to go over the two main schools of thought around back pain and figuring out its mechanisms, and then I'm going to describe my methodology of getting to the bottom of the problem. I like to broadly divide these schools of thought into the patho-anatomical model and the patho-psychosocial model. Let me explain what this means. Let's begin with the patho-anatomical model. You may have been to a practitioner of some sort who has taken some x-rays of your spine and then shown you a picture of what is supposedly a normal x-ray compared to yours, drawn some stupid lines and explained to you that this is the reason why you have back pain. Or maybe you've had an MRI scan of your spine and it's been explained to you that you have some dark discs in the spine, maybe some overgrown facet joints, some thickened ligaments, or even a spondylolisthesis where one bone has moved forward ever so slightly over another. What often happens is that based on findings on your scans, we jump to conclusions without properly tying it in with your history, the clinical examination findings, and the mechanisms that you describe that bring on your pain. A recent study that looked at MRI scans in people without back pain of different age groups actually found a lot of these findings that we see, such as dark discs, bulging discs, tears in the disc lining, or even degeneration, wear and tear of the facet joints, are very common throughout all age groups. Unfortunately, as a result of this, I've seen patients undergo various treatments, including adjustments or manipulations, exercise programs, sometimes even surgery, and all that this has done is make things worse. A big rule in medicine is treat the patient and not the test result. So, a thorough assessment from an experienced practitioner or clinician is really important, and also good understanding of scans so that you can tie in the symptoms of a patient with the scans and really understand if they two fit together. Quite a famous practitioner, Professor Stuart McGill, who I've interviewed on this YouTube channel, has done a lot of extensive research in the area of the biomechanical model or the pathoanatomical model and really knows how to get to the bottom of the cause in his clinical assessment of a patient. And many of the practitioners I work with actually use his techniques. However, extensive research carried out by Professor Peter O'Sullivan, a famous professor of physiotherapy in Australia, who I also interviewed on my channel, has shown that this pathoanatomical model doesn't really correlate with the majority of patients, and therefore a lot of the techniques that we commonly use, such as core strength exercises by physiotherapists, various osteopathic techniques, or even surgery, won't often work. This is because pain in general is a complex process. At the start of it, if we think of pain as a big jigsaw puzzle, pathology, the actual cause of the pain, may have made up most of the pieces of the jigsaw puzzle. But over time, as things heal up, as things scar over, that is only one small piece of the driving factors. Things like fear, anxiety, stress, false beliefs have been proven in numerous studies to be potent amplifiers of pain. So we think of this as the patho-psychosocial model. Many practitioners I work with have also trained in Peter O'Sullivan's techniques, which involve drilling into all these different factors that could be amplifiers of pain and tackling each one at a time. A lot of the therapy does involve long conversation to try and disprove any abnormal beliefs and drill into all the different driving factors, but it doesn't ignore some of the anatomical models. They look at the ways patients move as a result of what they believe, and if this is infecting their back pain or triggering it, making it worse, and trying to adapt these functional movements. And a lot of the research has demonstrated a significant benefit in this way of thinking and this type of therapy, which is called cognitive functional therapy. So at the Spine Multidisciplinary team, we try and put all of this together. If there truly is a patho-anatomical cause, an actual structural cause, and what I mean by that is the findings of the MRI scan truly match the patterns of pain that you have, the patterns of behaviour and the clinical examination findings, then yes, there may be a role for a specific exercise program that addresses that, and sometimes even surgery. If, however, there are multiple other factors involved, as we've discussed earlier, then we do try and drill into all those as well and therefore apply both models simultaneously. I believe the research carried out by Peter O'Sullivan and Professor Stuart McGill has highlighted the importance of bringing together all the skills of the different professionals that treat back pain, chiropractors, osteopaths, surgeons, so that we can find the best solution. And that's what we try to do at the Spine Multidisciplinary team. If you found this video helpful, please click that like button and please subscribe to the channel. Also visit us at spinemdt.com to see how we can help you. Thank you for watching.